So, a very good evening, everyone. Today, I will be giving a presentation on psychiatric aspects of chronic headache. My presentation is a little bit extensive, so sorry for that. So, the outline of my presentation will be first description, then what are the risk factors, the psychiatric conditions that are associated with chronic headache, the psychological factors affecting headache, medication overuse headache and its management, medical management and psychological management of other causes of headache. Then we one case, and then at last I'll finish with references. So chronic daily headache is actually seen in approximately 4% of headache sufferers in the USA, Europe, US, South America, and Asia. It's not a diagnosis but a condition in which headache is persistent on a daily basis or near daily basis for a period of 3 months or more. Usually, it has been seen that headache occurs more than 15 days per month and persists for 3 months. We can say the patient is having chronic daily headache. So the most common cause of chronic headache includes chronic migraine, chronic tension type headache, and medication overuse headache. So what are the risk factors for chronic daily headache? The modifiable risk factors are obesity, medication overuse, stress management, sleep apnea, diet, and chronobiologic behaviors like sleep, eating, and exercise schedules. But there are also unmodified factors like episodic migraine, female gender, low socioeconomic status, less education, head and neck trauma, and abuse as a child. So now when we talk about what are the psychiatric conditions that is associated with chronic headache, the first and foremost is depression, and as much as depression is common, anxiety is also very common. Then there is somatization disorders. Then we have dependency and withdrawal. Headache is also associated with mania, delirium, and post-traumatic headache at last. So when we talk about depression, the most common psychiatric disorder associated with chronic headache is depression. The neurovegetative signs in chronic pain like irritability, decreased appetite, decreased sleep, social withdrawal, and social and somatic preoccupation is seen in both in chronic headache patients as well as patients of depression. And it has been seen actually that chronic headache is actually more common in patients who are having dysthymia and bit of anxiety as well. And in these patients, actually the intensity of the pain varies with the intensity of the mood. And whereas chronic headache can also be seen in moderate depressive disorder and adjustment disorder patients, but in such patients, the intensity of the pain doesn't vary with the intensity of the with the effect of mood. Now, as I mentioned earlier, anxiety is probably as common as depression in chronic headache patients. Panic and phobic disorders can coexist with headache, and the most common form of anxiety which is seen in these patients is actually apprehensive state and being worried a lot, which is also seen in depressed patients. And anxiety is actually most of these patients is often focused on the pain. Now, when we talk about somatization disorder, that headache can be part of conversion disorder or somatization disorder. In conversion disorder, what happens is that the presentation of symptoms is very dramatic, and the sign and symptoms they does not match any cases of migraine or in tension type headache, and one can easily find some conflict going on in patient's life. Whereas in somatization disorder, the patient can come with vague somatic symptoms which is affecting in almost every organ system, and treating these patients in the long term is not very overly successful. Now, how chronic headache is related to dependency and withdrawal? It is actually not very common to see patients taking a lot of medications to treat their headache. The most commonly used are opioids, barbitals, benzodiazepines, eco-derivative, NSAIDs, and triptans, as all these drugs are used in treatment of pain. And what happens is the withdrawal happens because as soon as you stop these medications, the headache comes back and comes back with more intensity, which was much previously. And stopping this medication is important to prevent any toxic consequences and to allow the introduction of a schedule of preventive drug maintenance. Now, how mania and chronic headache is related. So, in some patients who are having depression and chronic headache, usually we treat them with the low dose antidepressant as well. In such cases, the patient might switch and might go into a state of hypomania. He might present with symptoms of euphoria, decreased need of sleep, and a little bit of over expenses. In some cases, the patient can also switch from hypomania to mania. Usually, what is saying that if you stop the medication, if you stop the offending drugs, the patient usually comes down, the symptoms usually come down on its own within 48 hours. But if mania is not following this course, then it is highly likely that it's an independent mania and not a reaction of any medication. Now, delirium is actually side effect of medications, like I mentioned earlier. When we use monoamine oxidase to treat depression in such patients, which is a very highly anticholinergic drug, and when we use it with some other drug which is also anticholinergic, that can precipitate something like ectropic psychosis. So treating it is very easy. The patient might present with symptoms of having auditory hallucinations, visual hallucinations. The patient might be confused and restless. The skin might be warm and dry. And just saying that when you inject the patient with intramuscular vasostegument, the patients improve immediately. Now, there is also post-traumatic headache, which is a common sequel of any head injury. In such patients, actually depend with headache along with problem with their cognitive problems, their impaired memory, decreased attention span, and also some personality changes like increased irritability or altered behavior. So it has been seen actually with over time the symptoms of post-traumatic headache with associated psychiatric findings tend to abate. The associated depression sometimes improve, whereas the headache persists. Now, what are the psychological factors that affect headache? The first and foremost is psychological stress. Now, the stress can be actually life-changing events such as loss of something or the loss of some very important person in their life, or it can be a chronic stress like a unhappy marriage or an unsatisfied job. Personality traits like being active, being industrious, high approval motive, internal locus of control, and having persons are very highly ambitious. It has been seen that in such cases, the patients tend to have chronic headache. Now, learned behavior can be of two types: classical conditioning and operant conditioning. In classical conditioning, the headache can be associated with any stimulus or something like place, person, or some time. And when the patient is exposed to that stimulus, the patient can develop headache. In operant conditioning, the headache can become a source of attention for family members. Now, this attention can actually reinforce this headache. Now, in psychodynamic approaches, we actually look for conflicts in the patient's life, such as suppressed anger, guilt, sadomasochistic traits, and unconscious hostility, and so on. A little bit about medication overuse headache, which is actually the most common cause of chronic headache in developed countries. So, how it develops? It develops with increased use of medication that are used to treat acute episodes of headache. Either they are taking monotherapy or in polypharmacy. So how do you manage medication overuse headache? You stop the offending drug and you, like suppose if the patient is taking opioid or barbiturate, you stop the drug and change the formulation from short-acting drug to a long-acting formulation. And when you stop the drug, the headache tends to come back. So in such cases, you should start preventive medication early, and it takes time that preventive medication to show its effect. So till that time, botulinum toxin A can be tried for the time being. Now, for other causes of headache, the medical management can be divided into two types. For acute attack, to avoid an acute episodic attack, you can treat the patient with pharmacological therapy, and to prevent treatment, we can use some drugs to reduce frequency, duration, and severity of headache episodes. So in this, actually, we can see for tension type headache, for the acute management, we can use paracetamol, aspirin, NSAIDs, and for the purpose of prevention, we can use amitriptyline, mirtazapine, and venlafaxine. Whereas for migraine, as we all know, we can use paracetamol, aspirin, diclofenac, ibuprofen, and for the purpose of prevention, we can use beta blockers, tricyclic antidepressants, topiramide, and calcitonin gene-related peptide monoclonal antibodies as well. Now, psychological management becomes a very important part in management of this patient. The first and most important is stress management. So, stress management can include the relaxation techniques, guided imagery, biofeedback, and leisure activity. The purpose of stress reduction is to eliminate as much as possible the constant tension that is found in muscle contraction and mixed headache that contribute to the pain. Psychoeducation is also very important. It plays a very important part because if you teach a person that how tension, worry, pressure, overwork, and overactivity is actually responsible for this headache and depression, then the patient will actually try to change his behavior and make an attempt to change his lifestyle. Aerobic exercises has been seen to be very important in helping patients of chronic headache. A minimum of 20 minutes of aerobic exercises is recommended daily. Sleep, as we all know, is very essential for good health. It has been seen that patients who maintain a good sleep hygiene and good sleep cycle, in those patients, the headache tends to subside early. Diet is, we have seen headache is associated with fasting, overeating, and eating specific types of food. And this has been in headache literature for hundred of years. We can avoid eating certain kinds of food, and there is a general perception that the people who eat their meal on a regular schedule and who are actually very consistent with their diet, they tend to do better than people who are not very consistent with their dietary behaviors. Now, there is a case which I wanted to present. A 40-year-old female patient, homemaker, she presented with complaints of headache, throbbing type, which was associated with photophobia and phonophobia. The patient also had nausea and vomiting, which was associated with pain. Initially, the frequency was around 2 to 3 days a month, and she used to get relief by taking naproxen 500 mg. But in the last 3 to 4 months, the frequency, intensity, and severity of headache has increased, and naproxen was not helping her anymore. She also reported of anxiety due to multiple issues. We indicated that the patient was suffering from generalized anxiety disorder. On investigations, the CT brain pain was normal and fundus was also normal. So the patient was started on amitriptyline and dose was had to 25 mg. We also gave the patient a low dose of sertraline to reduce her anxiety. And the active relief medication was changed from naproxen to a combination of paracetamol and domperidone. These are my references. Thank you.
Thank you Amit, for your comprehensive presentation. So, in presence of psychiatric comorbidities, it becomes very difficult to distinguish whether it's a primary headache or it's a secondary headache. Even the anti-migraine medication, some of them commonly used like beta blockers, flunarizine, valproate. On chronic use, they can present with depressive symptoms, and overuse of triptans and over-the-counter vasopressin tablets, they can present with anxiety-like symptoms. Topiramate is also notorious for causing mood symptoms. So there can be iatrogenic causes of psychiatric symptoms in these patients also.
Oh, very nice presentation. Any questions?
Thank you for the nice presentation. And now I would request Professor Shuporno Ganguly sir to felicitate the speakers and the panelists.
As we move on for the